This is the CMAC, which can be used as a traditional laryngoscope or with a video monitor that can record images. A flexible cable attaches the familiar feeling CMAC laryngoscope to an external video screen. The monitor displays a video feed from the tip of the laryngoscope and provides light and power to the camera through one cable attached to the scope. The CMAC is attached to the monitor by an electronic module that slides into the handle of the laryngoscope. It can be fitted with any of several interchangeable blades. When intubating with the CMAC, you can choose from the same MAC and Miller blades you're already used to. You can also opt for the difficult airway blade, or D blade, for particularly anterior or difficult airways. We'll talk more about the D blade later. For now, let's focus on the traditional blades. Finally, the pocket monitor. The pocket monitor attaches directly to the CMAC handle in place of the electronic module. It replaces the larger external monitor with a compact, battery-operated, portable display. Video-assisted laryngoscopy provides several advantages. Because the video camera allows the operator to see around the curve of the pharynx without needing to create a direct line of sight to the glottis, video assistance allows a view of the glottis using less force, reducing inadvertent trauma to the mouth and airway. Also, the external monitor facilitates teaching of both video-assisted and traditional laryngoscopy. Finally, when fitted with a traditional blade, the CMAC still allows intubation using a direct laryngoscopy technique. Let's start with a quick look at setting up to intubate with the CMAC. Based on your airway assessment of the patient, select your desired blade. Here, we'll focus on the traditional MAC blade. Slide the electronic module into the handle to connect the laryngoscope to the monitor. Turn the monitor on and set it within easy view of the intubator. Or you can use the pocket monitor. The pocket monitor is useful if you're intubating in the field or in a cramped location. The pocket monitor slides into the same CMAC handle using the same choice of blades and provides a small display. The remaining battery life is displayed here. Once clicked into place in the handle, activate the pocket monitor by flipping the screen out and up. There are no additional controls to activate the pocket monitor. Once you're set up, the pocket monitor and the original CMAC function the same way. Here, we're working with the original. There are 3 different ways to use the CMAC. First, you can use the CMAC to perform a video-assisted laryngoscopy. This technique is similar to, but slightly different from, what you're used to, and learning these differences will be the main focus. Second, you can always use it to perform a traditional direct laryngoscopy. This is particularly useful for teaching the DL technique to a learner and can also serve as a backup in the case of an equipment failure. Use a standard blade, ET tube, and stylet to intubate just as you always have, or use the video feed to closely supervise a learner's intubation attempt. Finally, the CMAC can be fitted with a difficult airway blade, which provides a steep anterior curve to easily visualize difficult airways. We'll look at this technique later on. You can use any of the traditional blades based on your airway assessment when using the video-assisted technique. You can also opt for the D blade. With the D blade, you will need to use a stylet. We'll talk more about intubating using the D blade and a stylet later on, once we've covered the basic video-assisted technique using a traditional MAC blade. Okay, we've pre-oxygenated our patient and we're ready to intubate. We're going to see how the video-assisted technique can make intubating with a traditional MAC blade easier, and then we'll take a look at some trouble spots you may run into. Begin by sliding the electronic module into the handle and turning on the monitor. As always, to intubate the patient, you'll need to visualize the glottis, move the end of the ET tube through the pharynx to the glottis, and then advance the tube into the trachea. Remember, we're talking about intubating using the video-assisted technique with the traditional MAC blade. While you can perform direct laryngoscopy with the CMAC, the technique is a little different. With traditional direct laryngoscopy, visualizing the glottis is usually the hardest part. Video assistance is going to make this step a lot easier. For direct laryngoscopy, you position the patient into the sniffing position to create a direct line of sight through the pharynx to the glottis. But here, the camera is going to do the seeing for you, so keep the head neutral with the face parallel to the ceiling to make placing the tube easier. Alright, we're in position. Start with your eyes on the patient and insert the blade into the mouth until the tip of the blade appears on the monitor, and then look to the screen to see your view of the airway. Advancing the blade too far will limit your field of view and give you less space to guide the tube into place. If you're having trouble here, back the blade out slightly. You're used to inserting the tube from the far right to avoid obstructing your line of sight to the glottis. But using the video-assisted technique, the image on the screen comes from the tip of the blade, so you don't need to worry about obstructing your view. Insert and advance the tube in the midline and follow the curve of the blade straight to the glottis. Last step, advance the tube. This can be a little bit tricky. Here's why. Look at the shape of the airway in the neutral position. You can see that navigating the curve of the hypopharynx is a problem. With direct laryngoscopy, we get around this problem by extending the neck into the sniffing position to straighten the path out a bit. But the goal is advancing the tube into the trachea, which actually angles back posteriorly just distal to the glottis. So while the sniffing position makes seeing the glottis easier, it also makes advancing the tube into the trachea harder by exaggerating this angle. The video-assisted technique allows you to see around the curve of the pharynx without extending the neck, and then advance the tube with a straight shot from the tip of the blade along the midline. Since you don't need to approach with the tube from the side, and you don't have exaggerated angles to navigate around, you should be able to place the tube easily without a stylet. Okay, so we've just talked about using the video-assisted technique to intubate using a MAC blade. Remember, you can use the same equipment to perform traditional direct laryngoscopy in the case of an equipment failure or to help a learner. What about the difficult or very anterior airway? This is the difficult airway blade, or D blade. Compared to the traditional MAC blades, the D blade has a steeper anterior curve. This shape takes full advantage of the video camera to visualize a very anterior or otherwise tricky airway. The angle makes visualizing the anterior glottis easier, but you'll need to navigate the ET tube around the steeper angle using a stylet. There are no special ET tubes or stylets for the CMAC. If you're using the D blade, just insert a regular stylet. Put about 35 degrees of bend on the end of it, just like usual. Remember, your natural urge is to bring the tube in from the far right to bring the tip of the ET tube to the glottis without obstructing your direct view. Don't. Once you visualize the glottis using the D blade, advance the tube in the midline, using the steep curve of the blade and the bend of the stylet to guide the tube to the glottis. That's intubating with the CMAC. Take a second to remind yourself of the key differences between the video-assisted technique and traditional direct laryngoscopy. Keep the head in the neutral position. Insert and advance the tube midline along the blade, and advance the tube into the trachea without a stylet. Remember, if you choose to use the D blade, you're exchanging an easier view of the very anterior glottis for a less direct course for the tube. Still insert and advance the tube midline along the blade, but use a stylet to navigate the steeper curve.